presentation.
तो इसमें नहीं आएगा ये old version है.
Uh, so the topic given to me is TKI free remission in CML. It is a small topic because we need to stop the drug, not start the drug. So it takes more time to start the drug or think about it, but it takes less time to stop the drug. So I would not be taking more than 12 minutes. So the current goal of CML therapy is TKI cessation because already we have achieved a similar OS to general population when a CML is diagnosed above 40 years of age. So why TKI cessation has become a key endpoint of therapy? That is because of long-term TKI therapy has potential for organ toxicity, proven negative impact on quality of life, and there is associated high cost burden of lifetime TKI therapy. Because in some cases we need disease-free interval just to carry out safe pregnancies in women of childbearing age. In day-to-day OPD practice, we probably face these situations also, and we can discontinue TKI now because we have evidence of TFR or operational cure that can be possible. So TFR or operational cure refers to having a stable, deep molecular response without the need of ongoing TKI treatment. We are not still saying cure because TKI don't act on CML leukemic stem cells and that doesn't eradicate CML leukemic stem cells. That is why we are using the term operational cure or treatment-free remissions. So the different goals of therapy can be because of the different age groups that we cater to. Patients younger than 50 years are expected to live more than 30 plus years. So in that case, inducing a durable DMR may be potentially lead to therapy discontinuation, whereas in older patients, therapy discontinuation is not of a primary concern. In that age group, probably we don't think about DMR or discontinuation much. And looking upon the data from India, that median age of presentation is a decade younger in comparison to the data presented in European or American literature, where probably need more of TFR. Now, in this era of shared decision making, probably patient's perspective is also important to know what they think about TFR. And if you look upon the first 4 reasons why patient wants TFR, it is all drug and drug side effects. So when the disease itself is not troublesome, the drug becomes one for the patient and the physician. So in that case, we see that majority of the patient has responded the reason for TFR as being either the drug or drug side effect or expected side effects of drug for long-term use. Now, we will look upon some evidences generated over the use of TKIs. We can see here, this is STIM-1 trial, which was actually the proof of concept trial started in 2007 and published in 2010, where it was shown that yes, TFR is possible in imatinib treated patients. And there are other different trials also, which were done with imatinib upfront second generation TKIs and in second line therapies as well. We will, in the next few slides, we'll probably run through those evidences. So summary of key imatinib TFR studies that we can see measure most of the trials have taken a cutoff or TKI treatment duration of 5 years, that is in excess of 59 months. And there is a response required for TFR is undetectable for more than 2 years. So undetectable level of BCR-ABL at 4.5 log sensitivity means at least it is undetectable below the level of 0.0032. That is molecular response or MR 4.5 or that is around MR 4.5. And a molecular relapse was defined as loss of MMR. And this was also the time point when TKI was reinitiated. And we can see across trials that a TFR rate of 40 to 50% was achieved in these imatinib treated patients who were in DMR. Now, if you look upon the kinetics of relapse, you can see that almost 90 to 95% of the relapses has happened within 6 months of discontinuation. And almost none of the patients has relapsed after 24 months of TKI discontinuation. So probably by knowing this kinetics, this warrants a more frequent monitoring, and that will probably see in the guidelines also that for first 6 months, there is monthly monitoring of BCR-ABL levels. And from safety perspective, it was also proven in these trials that resumption of imatinib produced undetectable MRD in nearly all the patients within 6 months of reinitiation. So if you can see, when we start 100 patients on imatinib, the 60% patients will have some durable response with imatinib. 40% of these patients with durable response will be eligible for TKI withdrawal, and almost half of these will have 40 to 50% will achieve an operational cure. So in all, overall, we can see that if you start 100 patients on imatinib, only maybe 15 to 20 patients will finally achieve operational cure if things go well. Now, how can we just increase these TFR rates? So the TFR rates can be increased by having more and more patients who achieve DMR rates. So we have seen already in different trials that higher TFR rates can be achieved with second generation TKIs due to relatively deeper and more sustained molecular responses. Now, to look in this data, it is the head-to-head trial of second generation TKIs with imatinib. In that, we can see that MR4 and MR4.5 rates are higher in second generation TKIs as compared to imatinib. And there is almost a 20% advantage, or a 20% more patients will achieve a DMR. And hence, in the long run, the 20% more patients will be eligible for TFR studies. And if you look on the graph, the separation of the curve happens as early as 1 to 2 years of TKI therapy. So not only more patients will achieve DMR, but they will achieve early. So there is a time advantage also with the use of second generation TKIs when we are really attempting, or we are really going to attempt TFR. Now, this is the summary of key second generation TKI TFR studies. In this, INEST, Freedom, and Eurosky is first line use of second generation TKIs, whereas other studies are based upon the first or subsequent line of TKI use, second generation TKI use. Now, even this group of trials, you can see that there is long-term TFR rates of 40 to 50% can be achieved. So the percentage of patients achieving TFR is not really increasing with use of second generation TKI, but more and more patients are becoming eligible to attempt TFR when we use second generation TKIs, and that ultimately translates into the advantage. Now that we have evidence, we will be deriving some guiding principles based upon this evidence. Now, and all the trials had excluded the accelerated phase or blast crisis patients. So TFR should only be attempted in patients who were CML CP at diagnosis, and they must have a quantifiable BCR-ABL transcript, because if you cannot monitor or assess the by RQ-PCR, probably we are not going to know when there is an early relapse. And any SOCAL risk group can be attempted as per NCCN and NCCN guidelines. And in the STIM trial, actually, SOCAL score was significantly associated with probability of molecular relapse after treatment. However, this data has not been confirmed in subsequent trials with imatinib or other second generation discontinuation trials. If you see, only the first line TKI or has been recommended to undergo TFR, because TFR studies have not uniformly clarified the impact of patients' history of resistance in probability of TFR. Probably when we are using a second line TKI, dasatinib or nilotinib, in that cases, some of the studies have shown that there can be different reasons for which we can start dasatinib or imatinib, that is either TKI resistance or TKI intolerance or physicians or patient's preference. So in that case, if there was prior imatinib resistance, in that case, the TFR rates were really low with dasatinib, and it was also lower in the STOP 2G TKI trial, in which imatinib and nilotinib both were seen. So there is almost 30% more relapses in those who had the prior imatinib resistance. So the TKIs discontinuation should only be tried in CML CP patients when only they have responded to first line TKIs and not in the second or third line. TKI duration is important because the trials such as STEAM and Eurosky have shown that if the longer duration of TKI for which it was given, the relapse rates were lower. For example, in STEM trial, when imatinib was given for more than 50 months, the relapse rate was 53%, whereas for a cutoff of 50 months or less than 50 months, imatinib exposure had a relapse rate of almost 83%. And depth and duration of MR, DMR. So DMR can be MR4 or 4.5. So in several discontinuation trials has established that even MR4 for at least 2 years as the criteria for considering treatment discontinuation. So we derive this. So as we had the evidence, now we have derived the guiding principles, and based on these guidelines have been designed. Leukemia net or ELN discontinuation study is actually more stringent as compared to NCCN, which doesn't happen usually because NCCN is more stricter and advanced as compared to European guidelines. But here the leukemia net guidelines are more stricter, whereas NCCN guidelines just only recommends more than 3 years of TKI with MR4 duration of 2 years, more than 2 years. And all these guidelines uniformly recommend monthly monitoring of RQ-PCR, monthly monitoring of BCR-ABL in the first 6 months, whereas 2 monthly in 6 to 12 months, and 3 months thereafter. So this is a common scenario in OPD. To end the slide, this is the last slide actually. In that we are confronted with this question: what to do when the patients want disease-free interval to attempt pregnancy, when you don't actually have TFR meeting criteria. So there is no schema or there is no guideline regarding this, but based upon the previous studies, case reports, and one of the papers which was called LET scheme presented in EHA 2018. It is not actually a full paper, but probably with the paucity of data, the data is going to the data is always going to be sparse in this scenario because of ethical reasons. So whatever data that we have, we can derive some principles or a schema for attempting a disease-free interval or a TKI-free interval for planning a pregnancy. For example, MMR or more for more than 2 years, because achieving MR4 or 4.5 for more than 2 years is not always feasible in our scenario. And when we stop TKI, there should be a minimal time gap between stopping TKI and conception, which can be curtailed by assisted reproductive techniques. And once you stop TKI, monthly CBC and BCR monitoring should start straight away. After conception, there are some principles which we can guide, such as while monitoring, if we see that at least MR2, that is BCR-ABL level of less than 1% is maintained, in that case, observation without IFN is optimal choice. If there is loss of CHR within 15th week, we are taking a cutoff of 15th week because TKI is given after 16 weeks have dual advantage because they don't actually have embryo toxicity because the organogenesis has already occurred and the placental maturation has occurred. So the drug which is not going to cross placenta is actually not going to reach fetus. Which is the case with imatinib and nilotinib because they are the larger molecules and they don't cross placenta. Whereas dasatinib is a smaller molecule and that crosses placenta. So with all its schema and available evidences and association of fetal hydrops with the dasatinib, probably dasatinib is not a choice in pregnancy. So it should not be given in any trimester. If you have to give some TKI, if you have no choice other than TKIs, then probably you can start after 16 months, and imatinib and nilotinib is an option. Because in this LAT schema presented, out of 46 patients, 26 patients were started on imatinib and nilotinib after 15 weeks, and in, none of them had reported any adverse events. And so after delivery, probably some time it should be given in breastfeeding, particularly in our setup. And in that case, once the TKI is started, probably the breastfeeding should be avoided. So this probably acts as a rough schema. Probably you can try disease TKI-free interval for planning a safe pregnancy. So I just end my presentation.
Thank you, Dr. Sujeet. For the lack of time, I would defer the questions from the audience. Should we progress to next session now?